today's Unit 3 class of Medicine Department. Today we are going to discuss a very important and very practical thing, that is an endocrine emergency, which we come across in every emergency duty, and that is therefore it becomes very important to know the practical aspects of this endocrine emergency, which is called DKA. This is called diabetic ketoacidosis. Therefore, first of all, we must know how to diagnose DKA. For diagnosis of DKA, we need certain things. Number one, there are criteria for diagnosis of DKA. When you will diagnose something as DKA, when the blood pH will be less than 7.3. Less than 7.3, 7.2, 7.29. Number two, when the bicarbonate concentration is less than 80 millimole per liter. And number three, when the random blood sugar is more than 250 milligram per deciliter. These are the lab criteria. These two information will come after ABG, and this will be done by your simple glucometer testing. So these are by and large lab-based testing. And whenever you find in emergency a patient is having blood sugar more than 250 milligram per deciliter, how you will suspect that this patient might be having diabetic ketoacidosis? So there will be some symptomatology also. Symptoms of DKA. Very important symptom is abdominal pain. A patient of diabetes having sugar more than 250 and he is complaining of abdominal pain, it might be the symptom of diabetic ketoacidosis. Number two, he may altered mental status, like confusion, irrelevant talk, even patient becomes unconscious. So these are important things: abdominal pain, vomiting, altered mental status. And there are some, you should know some precipitating factors of DKA. That is also very important. A patient of diabetes who develops precipitating factors. This is equally important because many times patients who are diabetic, they are prone to ischemic heart disease. So whenever a patient of diabetes develops ischemia, the chances of deteriorating diabetes into diabetic ketoacidosis is very high. And you do ECG and you find ST depression or ST depression in two consecutive ST depression or T wave inversion in two consecutive leads, then it becomes ischemia. Or when you have frank ST elevation MI, then in that case you should also do the ABG of the patient to rule out diabetic ketoacidosis. So precipitating factors can be myocardial infarction or ischemia, myocardial ischemia. Number 2, CVA. A patient of diabetes develops CVA. In CT scan you see infarction or hemorrhage. CVA too can precipitate diabetic ketoacidosis. So whenever you see any patient who is having CVA and check the blood sugar, it is more than 250, then go for the ABG and rule out the diabetic ketoacidosis, because diabetic ketoacidosis is deadly if it is untreated. It will certainly lead to death if it will be left untreated for long period of time. Number 2, infection. Patient is a diabetic patient who is febrile, meaning thereby there is some infection. Dehydration. So these are important things, these are practical things which you can easily gauge in your clinical practice, and you can rule out whether the patient is having these precipitating factors like myocardial infarction or ischemia. You can do it with the help of ECG. Whenever you find more than 250 blood sugar, your first duty is to rule out diabetic ketoacidosis. Blood sugar more than 250. First of all, you have to rule out diabetic ketoacidosis, and you have to look for the symptoms that I have already enumerated or the precipitating factors. And if those 3 criteria will be found, blood pH less than 7.3, bicarbonate less than 18 millimole per liter, and blood sugar more than 350, label it as diabetic ketoacidosis, and its management will be totally different than simple hyperglycemia or diabetes mellitus. So this is, now we can come to the management part. Though it is simple, but it has to be done timely so that we can get the desired result. There are 2 important things to understand about the diagnosis of diabetic ketoacidosis. Actually, in such patients, they are invariably dehydrated patients. They might have some other comorbidities also. There is deficit of fluid deficit of nearly 8 liter. 8 liter of fluid deficit. There is deficit of 8 liter fluid deficit in case of diabetic ketoacidosis. So we have to take care of this one, and number 2, we have to take care of raised blood sugar also. So these things you have to manage 2 things: fluid deficit as well as hyperglycemia. So basic principle of the management of diabetic ketoacidosis. Management of diabetic ketoacidosis. We have to handle principles of management. Number 1 is management of fluid deficit. And number 2, management of hyperglycemia. Okay. But one thing I would say, before you start doing management, you must have the ABG, because without ABG you cannot confirm the diagnosis. And in ABG you also look at one very important electrolyte, that is potassium. Yes, and this is very important because we have to give IV insulin in case of diabetic ketoacidosis. And IV insulin causes intracellular shift of potassium. So if, and that can cause hypokalemia, and hypokalemia is dangerous because that can cause cardiac asystole or arrhythmia that might lead to cardiac arrest or death of the patient. So what is to be done? We have to look at the potassium. For fluid deficit, so let us start with the fluid deficit. I will be talking about potassium when I will be talking about administration of intravenous insulin, because before starting that one we have to take one precaution, and that's why I have told you at the outset itself. So fluid deficit. A very fundamental principle of fluid deficit is that 1 liter, 1 liter, 1 liter and 1 liter. First 1 liter has to be given in first 30 minutes. Okay. Second 1 liter has to be given over 1 hour. Third 1 liter has to be given over 2 hours. And fourth liter has to be given over 4 hours. And how you will give 1 liter in 30 minutes? We have to accordingly calculate the drops, and it might be necessary to give 2 intracats simultaneously and give 2 drips simultaneously, because that is not possible because your 15 drop is equal to 1 ml. So suppose you have to give 30 minutes. In 30 minutes, 15 drops is equal to 1 ml, and you have to give 500 ml in 30 minutes. So in 1 minute, you have to give 500 divided by 30 into 15 drops. This is ml. 500 ml in 30 minutes. In 1 minute, you have to give 500 divided by 30 ml. This is in ml, and we have to convert in drops. How many drops we will be giving? So if this 15 divided by 250 drops per minute. This is very difficult to achieve. So what we will be doing, we will be using 2 intracats for giving. Means we have to give at the fastest possible rate, because until you treat the dehydration, just merely treating giving insulin will not work. Why just giving insulin does not work in DKA? Because in DKA you have to manage the dehydration portion, because the more the patient is dehydrated, the more will be the chances of acidosis, and that further deteriorates the condition of the patient, because acidosis leads to cardiac asystole also. In acidic environment, proper pumping of heart is also not possible. That's why such patients are also hypotensive. So to improve the cardiac function, so this is the principle. In first 1 liter has to be given in 30 minutes, second 1 liter has to be given 1 hour, 2 hours, 4 hours. So this becomes nearly 8 hours. So first 4 liter will be given in 8 hours, and next I told you the total fluid deficit was of 8 liter, and in next 16 hours, next 4 liter will be given in over next 16 hours. This is the principle. After that, you can relax. In 16 hours, we can easily give, even if we give 500 ml or ml in 2 hours, that will easily cater our need. For giving 4 liter in 16 hours is not tough job. First 4 liter should be given in first 8 hours, and next 4 liter deficit should be managed in next 16 hours, and you can accordingly manage. Yes, you have to look sometimes what happens. We have a catching situation. You will be finding the patient is very much hypertensive, or patient is also having cardiac failure. There is already pulmonary dip and fluid overload. In that case, you cannot go for that aggressive fluid deficit. But you should in general know that you have to take care of the fluid deficit. And usually happen if DKA is the complication is commoner in type 1 diabetes or type 2. No, we see more cases of type 2 in our emergency ward. That's why we encounter diabetic ketoacidosis in them. Type 2, type DK is basically fundamentally more common in type 1 diabetes mellitus. And type 1 patients are usually young patients, and in them chances of comorbidities is less, like heart failure or CDA. Therefore, DKA management, you can go for fluid therapy very liberally, because such patients are usually, because you have seen more and more cases of type 2, that's why you find DK in type 2, but it is more common in type 1. Okay, so giving fluid is not that much difficult when the patient is 14 years, 16 years, 18 years. You will also see in your clinical practice as you will proceed in future. You will see that you ultimately, and I am telling you, make a long-term assessment starting from this 31st October 2023 to 31st October 2024, and measure how many cases of diabetic ketoacidosis belongs to type 1 and type 2. Then you will find the more number of cases of DK will be found in type 1. If you observe over a extended period of time, meaning thereby if your sample size will be large, then the chances of error will be less. If you see just one case of DKA, it might be type 2, and you cannot say that 100% of the DKA is of type 2. No. So this is the management of fluid management, and that is very important. And second part that is equally important is management of hyperglycemia. Management of hyperglycemia. Before starting treatment of hyperglycemia, you will have to look for the serum potassium in your ABG report. That's why ABG is very crucial in diagnosis as well as management of diabetic ketoacidosis. If the patient is having potassium which is more than 4 millimole per liter, then you can safely go for insulin, IV insulin, and if it is less than 4 millimole per liter, then you will have to give first potassium, and after correcting potassium only you can give the insulin. Otherwise patient will develop severe hypokalemia and there may be cardiac arrest and you may lose the patient. So if the serum potassium is more than 4 millimole per liter, you can safely go for IV insulin. IV insulin, because IV insulin causes intracellular shifting of potassium ion, and if the patient is having serum potassium less than 4 millimole per liter, you will have to correct first potassium, and this potassium must be more than 4 to start IV insulin. Otherwise, treating hyperglycemia will be more dangerous than getting not treating hyperglycemia. So yes, it might take some time, because the maximum rate of correction of potassium is, you can give 20 milliequivalent, means 1 ampoule in 1 hour. So in that case you will have to go fast. You will just give it in 100 ml, not 500 ml, and go for 30 drops per minute, means 2 ml per minute. In that case, 100 ml will be finished in 50 minutes. So what you will give? 1 ampoule KCl, which contains 20 milliequivalent, and 100 ml. 100 ml. This sample is of nearly 10 ml, and this is 10. So 110 ml together, it will become 110 ml. That will be finished in 55 minutes if you will give it at the rate of 30 drops per minute. This should be very clear. This drop per minute, you should know this basic principle very clearly. 15 drops means 1 ml. In 15 drops there is 1 ml. So 30 drops per minute means 2 ml per minute, and this is 100 ml in 100 ml NS, and this ampoule is of 5 ml. It is of 5 ml, not 10 ml. It is of 5 ml. 5 ml or 10 ml. Sorry, it is of 10 ml. So together it will constitute 110 ml. So 110 ml will be finished in 55 minutes when we will give it at the rate of 2 ml per minute. Understood? So we will give potassium, and then we will then we can go for IV insulin, because that will correct. And meantime, we will send another sample for ABG, whether the potassium has been corrected or not, and it most of the times gets corrected. And this is how. So now the treatment of hyperglycemia per se. So one precaution that you have to take as a clinician, that before starting IV insulin, you have to take care of potassium in case of diabetic ketoacidosis. That's why its management becomes, now you can see very easily how it is different from hyperglycemia. Usual hyperglycemia, we just give 10 unit, 10 unit, 10 unit, and Basalog in night. It is very much easier. And how much detailed effort and hard work is needed when you find a case of BK. If in emergency you find one case in BK, on that day you should thank God that you have got the opportunity to get the blessing of God, because devoting entire 8 hours in that one patient is worth for that emergency. Always remember this. One DKA patient, if you find a DKA patient in your emergency, devote whole of the 8 hours of duty in that patient. That will be far more productive than giving around for other patients. Yes, we have to see others, but that patient is something whose life and death is related with your management. And even if you save one life in one emergency, that is far greater and better for your future, your family, and everything else, because God sees our action. And those are patients. That's why it is important. In crowd of emergency, you have to delineate 2 or 3 patients in every emergency, and make a concept of patient of the emergency. Like what theme, there is theme of the every event. like World Stroke Day, like that. In every emergency, you find in our college there is Mr. Personality or Mrs. Personality, like this. It is a provision in our fresher party. We give the title of Mr. Person or Personality. Accordingly, in every emergency, you should take one patient as the patient of the emergency. That will be the symbol of that day's emergency duty, and devote your time and energy for that patient. And a patient of DK can be the patient of your emergency. That is hero for you in that emergency, and you have to devote time and energy for that. So because this is very important case, and accordingly you should prioritize the patient, because you have 100 patients, but there are one or two patients who demand special attention here, and if you give that extra special attention here, his or her life might be saved. And this is one case where you can save someone's life. Yes, ultimate saver is God, but we are the instrument of God. We should understand it. Because God does His work through human being. This should be very clear to all of us. So hyperglycemia. In case of hyperglycemia, first we have to start with the loading dose. Loading dose is 0.1 unit per kg body weight. For all practical purposes, we assume, and it is practically true also, our patients are nearly between 50 to 60 kg. So you can go for 6 unit insulin IV stat. 6 unit IV insulin stat, and after that you have to give the same amount, although it is a coincidence, 6 unit of insulin per hour. After that you have given the IV loading dose or the bolus, you have to give maintenance dose. Maintenance dose. That is also 6 units per hour. 6 units per hour. And how you will give 6 units per hour? If you are your patient in ICU, you can give it through infusion pump, but that is not the case in our case. Most of the time we have to manage the case in general emergency ward itself. So what you can do, you can mix 6 units of insulin in 100 ml 100 ml and give it at the rate of 30 drops per minute. 30 drops per minute with advice. What will be the advice? 30 drops per minute to be continued. This has to be, if that will be finishes, we will have to again give 6 units per hour until to be continued until blood sugar level comes to 250 milligram per deciliter. Until blood sugar comes to 250 milligram per deciliter, because this was the basic level above which diabetic ketoacidosis happens. So first of all, we have to bring it down to the 250 level, and after 250 we have to give dextrose along with insulin, because if you give insulin alone, then chances of hypoglycemia will be very high. After that, when we have arrived at 250 milligram per deciliter, then what we will give? When you have achieved a major target, that is, you have achieved blood sugar to 250 level. You have achieved 250 level, then you will give DNS along with the IV insulin. At the same rate, 6 units per hour. And when it comes to 150, DNS will continue as, and you have to make it half. It will become 3 units per hour. And you will maintain this until patient starts taking orally, because in DKA most of the time patient is moribund, or patient is mentally confused, altered, and he is unable to take orally. When he starts, the level becomes, you have to maintain blood sugar at 150 and give DNS in 3 units per hour. And when patient starts taking orally, then is the time to think about stopping the IV insulin and switching it to the subcutaneous insulin. And for that, what we do, you will have to overlap subcutaneous insulin and IV insulin for at least 30 minutes, and then you will withdraw the IV insulin. Suppose you have given 3 unit insulin at the rate of in 100 ml at the rate of 30 drops per minute. Now you see your drip has come to an end. It will just last for 30 minutes. Suppose it is half empty, then you will give giving insulin, subcutaneous insulin, and in that case you will have to give mixed insulin, intermediate acting and short acting insulin alone, because just giving short acting insulin will not handle, because had it been the case, patient would not have gone in case of in diabetic ketoacidosis, because initially how patient went to diabetic ketoacidosis, his hyperglycemia was uncontrolled, and most of the time patients are already on insulin, because type 1 diabetes patients, they take insulin themselves, and even then they go to the diabetic ketoacidosis, because most of the time they take short acting insulin and they don't take the long acting insulin. So in case of when it is 150, we have to maintain it, and when patient is able to take oral intake, simply take as simple. When patient is able to take orally, you have to give you have to maintain DNS, and after that, when patient will be able to take oral intake, then he will have extra glucose and sugar. That's why we will be able to give DNS and 3 unit insulin plus subcutaneous insulin, because this is essential to give a subcutaneous insulin, because patient is maintained at this level without oral intake, and if we give additional subcutaneous insulin without oral intake, patient will go down to hypoglycemia. Therefore, when patient starts oral intake, this is the time to switch the patient to subcutaneous insulin. And how will we switch subcutaneous insulin? We give at least 30 minutes of overlap between IV insulin and subcutaneous insulin. So when your insulin drip comes to 50 ml, now it will last for next 30 minutes, then you can start subcutaneous insulin and patient will not go into and here you have to use the mixed insulin. Mixed insulin is intermediate acting and short acting, both insulin are there, and that's why it is very easy to handle the case, because this demands special attention and care. Diabetic ketoacidosis is not simply as hyperglycemia. It is a dedicated effort. It demands a wholehearted effort from the side of treating clinician. And if you find any one patient of DK, devote entire emergency day for that, because that is worth 10 other patients of just simply other things. because other chronic diseases or they are not going to kill your patient, or they are not going to even change much in their quality of life. But here is something where you can change the life of someone, and you should never miss the opportunity when God has entrusted you to really change someone's life. Yeah. So I think this is sufficient, and it was more informative and more practical for you. If you say, I can summarize once again. First of all, you have to, whenever you see in emergency a patient is having hyperglycemia, is diabetic, and patient is patient is dyspneic, or that is called too small breathing or air hunger. That is acidotic breathing, where patient is, that is abdominal thoracic in type. So first of all, the patient, a diabetic patient who is having dyspnea or abdominal pain or vomiting or fever or altered mental condition, your first response should be to rule out the diabetic ketoacidosis, and for that you should do the random blood sugar. It is usually 250. There are euglycemic diabetic ketoacidosis also, in which blood sugar will be less than 250. But in those cases, pH will be less than 7.3 and bicarbonate will be less than 80, and patient will have other symptoms of diabetic ketoacidosis like dyspnea, abdominal pain, vomiting, altered mental status. So you should treat it as diabetic ketoacidosis. And for diabetic ketoacidosis, you have to look up for two things. One is fluid deficit and another is hyperglycemia. For fluid deficit, I have already told, nearly there is 7 to 8 liter of deficit in case of diabetic ketoacidosis, and this deficit becomes 10 to 12 liter in case of HHS, hyperosmolar hyperglycemic coma. That is more dangerous, in which blood sugar level becomes more than 600 milligram per deciliter. You will have to take care of fluid deficit, and fluid deficit, I have simply told you, this is old but very effective things. You have to give first 4 liter in nearly first 8 hours and next 4 liter in next 16 hours. And that should be the broad thinking. And in case of before starting treating hyperglycemia, means giving insulin, IV insulin, which is 0.1 unit per kg body weight, you will have to check the level of potassium, because if potassium is already less than 4, you cannot go IV insulin, because that will lead to dangerous hypokalemia and you might lose patient. So you will have to take care of potassium, and if it is more than 4, then you can go for IV insulin. And even in that case, when the patient is having more than 4, you should check the potassium level. And if it starts going down, then you have to give potassium also. So be careful about potassium while giving IV insulin. In between, you will also have to check the level of potassium, because that is very important. And you will have to take care of other precipitating factors. If the patient is having CVA, treat the CVA. If the patient is having MI, treat the MI. If the patient is dehydrated, then we take care of dehydration. If the patient is having UTI also precipitates diabetic ketoacidosis. Treat the infections. And this is how you have to take a holistic approach about the patient. And if you do very sincerely, the result is very good in case of diabetic ketoacidosis. And if you miss also, the result is equally bad. So it is an opportunity as well as a risk for you. So you have to treat it as an opportunity to save someone's life, and you can do it. I hope and I believe. And I believe now I have given the best of myself today, and you have been benefited of today's lecture.